My name is Dr. Lisa Becht, and I'm a fertility doctor here at HRC Fertility in Orange County. My major office is here in Newport Beach, but we also have satellites throughout Orange County. And also, if you're just here in the Southern California area, we also have offices in the Pasadena region and Encino region. But I'm very excited tonight to be talking to you all about IVF. We said we'd start at 6:30. I know there was a lot of participants. It looks like people are still signing in. So I'll just kind of talk a little bit before we move into the actual presentation. But basically tonight we're going to talk all about IVF. So we kind of think it's fun to say kind of what the IVF. Definitely IVF is a pretty complicated process. Absolutely something that it seems like some participants have actually maybe already done a cycle and they're looking for more information. Other people that signed up look like they're getting information to try to decide if they themselves should do IVF. Kind of in terms of IVF, we're going to talk about everything from making embryos to using embryos to freezing embryos, and basically try to cover a lot of the questions. I really appreciate all the questions everyone was able to send in, and so I've done my best to try to really address the general questions as we go through the slides tonight. There were also some really good specific questions, kind of specific questions that are specific to people's age and hormone values, previous cycles, things like that. Definitely is just in a little bit kind of too specific detail to discuss tonight, but I absolutely would recommend that you consider making a consult appointment. You know, during a consult, I usually spend 45 minutes to an hour kind of going through everything kind of in a full process. Definitely, if you've done either previous IVF cycles or any type of fertility testing, we can go through that to really personalize the information to you. And then once we do workup, we always do a second follow-up just to really talk about what IVF would mean specifically to you, because it's so personalized based on someone's age, medical history, hormone values, other parameters in terms of fertility testing. So again, I'm going to try to cover all the big basics, definitely go into some myths, go through all the information. So you hopefully leave here tonight kind of really hopefully understanding the general practice of IVF. And then like we said, for very specific questions, I'd love to do a consult for you, or you could see, a fertility doctor in your area, but definitely, hopefully you will get some good information. There were also a lot of questions on cost. So here at HRC, definitely we do everything we can to make this as affordable as a process as possible. The first thing to really talk about cost is to actually have you talk to a financial advisor, which is part of your consult. They can really see, do you have any insurance coverage for at least the workup or hopefully maybe the treatment cycle? And from that, they can give you much better specific personalized cost. We do have some packages for patients that have no insurance coverage, which can definitely be great deals. But again, since it's so different from person to person, definitely with a consult, you'd be able to get very personalized information on the cost. So at this point, I'm going to start going through those slides. Definitely, you can see here, it's definitely an open forum. If you want to put questions in chat, definitely at the end, I'll go through that as well as kind of go through a couple of the very specific questions that I think are pertinent to everybody that you sent in before. Oopsies. So just to start off, the question is why IVF? So definitely people do IVF for various reasons. From the medical side, there's definitely someone might have a specific diagnosis that means they should do IVF. So just to kind of go through all of the things on the left, someone who has low ovarian reserve, meaning their hormone testing showed very low anti-Mullerian hormone or low number of follicles, which is where the eggs are. The concern is that your fertility window is decreased. And so oftentimes we might do IVF just to maximize your chances and also potentially get you extra embryos to freeze for the future. Also with that, hormone values and increased age, definitely just the chances are much higher with IVF than something like an insemination. Blocked tubes, that's a definitive reason to go to IVF. Blocked tube means that the fallopian tubes are not open, so the eggs and sperm cannot come together. And so we need to do IVF to essentially put the eggs and sperm together for you. Endometriosis oftentimes kind of links to the two above bullets. Endometriosis definitely can cause issues with the fallopian tubes. It can decrease ovarian reserve. It can decrease egg quality. And so really nowadays for endometriosis, especially if you have severe endometriosis, the studies have really shown that going to IVF is the way to go. It's even often for most patients more beneficial than a surgery, unless they have very specific reasons why they would need that surgery. Unexplained unexplained infertility, that's always a big question. So someone comes in, they have infertility, we do a full workup for the female and if she has a male partner, and from that everything looks good, which obviously is good, but then the question is, well, why is pregnancy so hard to attain? So with unexplained infertility, there are some couples that might be able to get pregnant with something like insemination, usually with a fertility pill like Clomid, but for a good percentage of them, often we think the problem is actually with the egg and sperm coming together, which is called fertilization. And so IVF is what's going to overcome that. So for unexplained infertility, definitely that's something, I would go into more detail if you're in my office having a consult, but with an IUI, if everything really looks good, essentially your chance of getting pregnant in a month with a Clomid IUI is maybe about 15% and possibly less if you're older. Whereas with IVF, the hope would be is if we can get you a good normal embryo, again, depending on different factors, hopefully that chance of pregnancy when we transfer the embryo is a good 65 to 70-ish%. So for unexplained infertility, definitely someone might try a couple IUIs if they'd like to, but a lot of times patients might go directly to IVF just for a much higher chance of pregnancy. Male factor, that means that there's issues on the sperm side. That's a huge indicator for IVF. The issue with low sperm that's not moving, sperm that has very poor morphology, is that sperm, it's a very long way to go from an ejaculation, either for natural pregnancy to an egg, or even with an IUI. And then even if sperm and eggs are getting close, if a sperm is poor quality or has very poor motility, the thought is it's just not able to get into the egg. And so by doing IVF with something called ICSI, which is intracytoplasmic sperm injection, that's going to help actually literally get the sperm into the egg to hopefully get you some embryos and try to overcome that male factor. Recurrent pregnancy loss, that's not a definitive indication to do IVF, but definitely some patients prefer to. With recurrent pregnancy loss, definitely if we could take out the possibility that it's the embryo that's causing miscarriage, and we can do that with IVF with PGT, which is pre-implantation genetic testing for chromosomes, absolutely that's a great way to at least know the embryo is normal. And then also with recurrent pregnancy loss, typically we want to add extra progesterone for hormone support. We might want to add steroids or blood thinners or other things. And so in an IVF frozen embryo transfer, we can really kind of maximize that protocol to really maximize your chance of not just getting pregnant, but hopefully staying pregnant. Previous vasectomy, that means that unfortunately there is no sperm in the ejaculate. So that's also typically a definitive reason to go straight to IVF. A vasectomy reversal, meaning trying to get a surgery to kind of refix that vasectomy, typically isn't that successful. And so IVF is typically the way to go. And then if you've tried other things, so if you've had IUI cycles, unfortunately, that have failed, that's when we start talking IVF. So those are all kind of more specific medical reasons. And then really there's also just specific desires. So like we said, for the much higher success rate, some patients come in and they say, I want to go straight to IVF. And we think that's definitely a very reasonable reason. Chromosome testing. So like we said, we do PGT, which is pre-implantation genetic testing. That's letting us check each embryo for all of the chromosomes. So as we get older, especially over 35, things like Down syndrome or other types of chromosome problems that aren't compatible with life, that's what's really decreasing our pregnancy rate and increasing miscarriage rate. And so by doing chromosome testing of your embryos first, before we do a transfer, that's how we're getting such a high pregnancy rate and we're decreasing your miscarriage risk by at least 50%. Sometimes patients are doing that a little bit more electively. Maybe they are kind of doing it for family balancing or otherwise known as gender selection. So they're trying to get maybe a gender that they don't have or that they desire. Genetic testing, which is similar, it's still testing embryos, but that would be if you carry a specific mutation. So some patients have a mutation such as BRCA or BRCA, which is breast cancer gene. If you have one copy of that mutation, you yourself are at much higher risk of various cancers, and there's a 50% chance that a child would get that. And so that would be something where sometimes patients want to check your embryos before picking kind of which one maybe does not have that. Additionally, if both the female and male have the same, what we call recessive traits. So let's say they both carry a cystic fibrosis gene. When you just have one, which is that carrier, it doesn't impact you. But if you're both carriers of the same thing, now a baby has a 25% chance of having that very severe disease. So we can actually check your embryos up front if that's something specific that we want to check for. Sometimes when we get into this part of the conversation, patients ask, well, can I check for autism or mental disease or things like that? This is really for very specific mutations, specifically linked to a definitive disease. So things that are a little bit more multifactorial, unfortunately, we would not be able to test for. Like we said, going into the next point, decreased miscarriage rate, because we know it's normal. And then last but not least, the ability to freeze extra embryos for future pregnancies, or sometimes patients do IVF solely to freeze embryos right now, and that's really called embryo freezing. So lots of different reasons. So I'm sure a lot of you are here for many of these. So now we're just going to go a little bit more into kind of what do we do before we actually get into an IVF cycle. So like we said, sometimes patients come in and they want to go straight to IVF. So we do a little bit more of a condensed workup. So we don't need to check your fallopian tubes or things like that since we're going straight to IVF. Other times patients come get the full workup, and then from that we can discuss what makes the most sense. But prior to IVF on the female side, definitely we want an ultrasound. So that's an internal or transvaginal ultrasound where we're actually going to count these little black circles on the ovaries, which are called follicles. Each one of those has an egg. The egg is microscopic, so we're looking really just at the follicle, which is kind of the house of the egg. So we can count those, and by counting those, we're able to kind of estimate how many eggs we think we could get you in your IVF cycle. So that's called an antral follicle count, and it's ideally done in the first couple of days of your cycle. Definitely a lot of misconceptions with IVF. Unfortunately, that antral follicle count is really kind of what we're working with when we think IVF. Our medications aren't really going to increase the number of follicles you have. They're just hopefully using the ones that you do have. So by using that along with the next line, which is the fertility hormones, as your doctor, I can try to make you the best protocol to hopefully get most, if not all, of those follicles with eggs to hopefully respond. So the very big hormones we want to check is a follicle stimulating hormone with estrogen. That's specific, again, to the first few days of your cycle. FSH is a hormone that comes from your brain and it talks from your brain down to the ovary. As we get older, it goes up. And as it goes up, it gets harder to get pregnant and harder to respond to IVF. So we want to know what that is to help dose your medications. And then AMH, which is anti-Müllerian hormone, comes from your follicles and eggs. So that's another indicator of kind of how your quantity is. So high AMH is good, lower AMH means less eggs. We do a full general checklist. We want to check things like your thyroid, vitamin D level, all sorts of different things, because if those are low, we could hopefully fix those before a cycle to hopefully get a better cycle for you. Along with that, we check things we need to be able to do a procedure, which we're going to do with IVF to take the eggs out. So your blood type, your blood count, things like that. We need to do an STD screen, so HIV, hepatitis, and all of that. And then last but not least, a carrier screen. That kind of goes back to that kind of talk about the genetic screening, looking for things like cystic fibrosis. And so that would be looking in your blood. It's one tube and it looks for about 300 different things. You know, what are we actually looking for? And in the small case, we do find that we need to test for that. We know ahead of time. On the male side of things, if you have a partner, definitely we want a semen analysis to know about sperm. Definitely the STI screen as well and the carrier screen. Or if you don't have a partner, we help look at some labs so you can pick a donor sperm. And then before getting into an IVF cycle, I'm a very big proponent, and you'll see that if you do a consult with me. I like to just go through kind of optimizing health before. Definitely, you know, from the medical side, our hormones and everything are important, but there are things that you could do to hopefully maximize your cycle as well. So sometimes where you see that I actually want you to take a month off or so to maximize that. So definitely we want to make sure your medical conditions are controlled. The big one there is your thyroid. So like we said, we're check your thyroid for you. If it is not in a good range, we want that fixed, because that definitely can impact how you respond to an IVF cycle. And then any other medical condition that might fall into that, you'll see that we put onto what we call our checklist for you. We want you to get clearance. So for example, if someone has major headaches, we know that headaches are triggered during IVF. So we want you to go talk to your neurologist so that there's a plan in place if you have horrible headaches. So things like that. And then vitamins and supplements, definitely important. So prenatals with DHA, so that's omega acid, super important. Coenzyme Q10 is an antioxidant. That is something, it's just over the counter. If you're not on it right now and you're trying to get pregnant, you should go get some. It basically, the thought is with females, we're born with all the eggs we're going to have. And over time, they're just being exposed to different things. And so there's damage to them. And so an antioxidant like coenzyme Q10 can hopefully fix that a little bit. That also goes for men. So coenzyme Q10 as well as vitamins for men can definitely be helpful. Vitamin D, if you need it, which most people do, absolutely also helps fertility. And then there's a lot of kind of specific things. So again, you would be personalized once you've gone through testing, but if you have PCOS, often you might need metformin. If you have very low ovarian reserve, you might need DHEA. NAC, melatonin, a lot of different things. That's kind of very personalized to specific people. So definitely don't go buy all of these. You want to be personalized. These are not going to help everybody. And then something a lot of my patients really like, there's a book that's called It Starts with the Egg. And it kind of goes through some of this and more lifestyle. I know IVF is a difficult process. And so I do feel like patients feel that if they can feel like they're more part of it, and there maybe are some things they could do on the diet side, eating, all different things, they want to be, more part of the cycle. And I definitely emphasize that. So healthy lifestyle. So definitely trying to be optimal in terms of your weight. Definitely, we don't want you to go on a massive diet right before IVF. That would be maybe a reason to take a couple months off. But definitely eating healthy, good exercise, just so once you're pregnant, you can still keep doing that. Decreasing alcohol and caffeine. Some patients will fully cut it out. Really the studies show with very minimal alcohol and caffeine, 1 to 2 cups a day. We don't see a negative impact, but that would be up to you if you want to fully cut it out. Definitely you should fully cut out smoking, marijuana, things like that. Stress reduction, I know that one's easier kind of said than done, but a lot of times patients actually like to do acupuncture, and that helps with stress reduction and hopefully maybe increases blood flow. So definitely we can give you all these hormones and do all of the medical side, but there's some things you can do hopefully prior to maybe maximize your response and output. So now we're going to get into the IVF process. So IVF, or in vitro fertilization, is basically trying to get eggs out of the ovary, take them out, put them in our lab, get sperm, combine them, make embryos, and then put an embryo back. Nowadays, most places, including HRC, IVF is actually really a 2-step process. The first part, which we often call the Ivf cycle, is making embryos. So we're going to go into that in detail. And then later, we're going to freeze those embryos, and maybe the next month or sometime in the future, we're going to do the transfer part. So really nowadays, we don't typically do fresh transfer. So IVF is really stimulation, making embryos, and then transfer process. So in terms of stimulation, so like we said, going into this, we have a little bit of an idea as to what we should expect egg-wise. That's from doing that ultrasound and doing your hormones. And so from that, your doctor is going to be able to make a protocol. We could literally do 20 slides on all the different protocols. So that would really be very specific to your situation, your numbers, your age, if you've done previous cycles, lots of different protocols out there. I would say a lot of times people will do some type of what we call suppression, meaning to start your cycle kind of counterintuitively, often we might give you something like birth control or luteal estrase. Those are medications that kind of quiet all of those eggs down. The thought is especially as we get a little older, you have your eggs on each side of the ovary, but only one of them would be your normal egg that would ovulate out. With IVF, we want to get all of them to grow so we can take them out. And so by kind of quieting down that dominant one, we usually can get more of them to grow, which is called synchronization. So often, a lot of protocols might start with something like birth control, just for a little bit of time. At least for my patients, I don't give you a whole pill pack or anything like that. It's very specific to that month. What does your ultrasound and blood work look like? And maybe you're on the pill anywhere from 1.5 to 3 weeks, depending on your estrogen and follicles. But basically, you do that, you then come back, make sure everything looks synchronized, and then at that point, you start the Ivf medications, which are injections. Oftentimes there's pens of the follicle stimulating hormone. There's lots of different names out there, but really the brand names here in the United States are Follistim or Gonal F. And then I always also like to give my patients Menopure, which is a powder that we show you how to mix. And that is thought to help a little bit on the quality side as well. Basically, those are medications to try to get lots of your eggs in the follicles to grow. Depending on the protocol, you might also do something like Lupron or microdose Lupron, which helps kind of keep you from ovulating or helps kind of overstimulate. or probably the most popular one is something called the Antagonist Protocol, which is something you add in as you start having the follicles grow. But basically that protocol is typically of the Ivf medications, usually 10 to 12 days of the injections. You come to the office every couple of days for ultrasounds and blood work so we can check in and see how you're looking. We measure each follicle, we check your estrogen and progesterone levels. And from that, we're able to change the doses around to try to keep getting as many of your eggs to grow together. So that picture you see is of follicles that are starting to grow, which is great. During that time, side effects, definitely you might have some headaches in the beginning, and then towards the end, hopefully if you have a good response, some bloating and cramping. But basically through that days of 10 to 12 days, we're going to hopefully try to get as many eggs to grow. Some people's ovaries go slower, some go faster. So we just keep monitoring you closely. And so we give you a calendar, but that definitely can change based on what your ovaries are doing. In terms of stimulation, unfortunately, a couple misconceptions. Like we said before, our medications are just able to get the eggs you have to grow. It can't get you more eggs that you don't have. Another misconception is those eggs every month, they come from the center of the ovary to the surface. And basically those are the ones that are available to be taken that month. They're all going to go away at the end of the month, whether we're taking them out or if you just ovulated one, the rest would go away. So we're not taking future eggs. We're not decreasing future fertility. But basically stimulation is very important because that's trying to get as many eggs to grow as we can, so that then on the day of your egg retrieval, we can get out as many as we can. So the egg retrieval, it's a procedure in an ambulatory surgery center or operating room. It is done typically under anesthesia. Definitely here at HRC, we do it under twilight. Usually you're checking about an hour early, you get your IV, meet anesthesia, meet your team. The procedure itself is literally about 15 minutes. It's that same ultrasound that you get kind of through the stimulation. Some people call it Wanda, but basically it has a needle on it, so that as your doctor, I can see everything on the screen. And basically I'm able to put the needle right through the vaginal wall, right into the ovary, and basically take the fluid with the eggs out from both sides. Very minimal risk, less than 1% for most people in terms of infection or bleeding or things like that. Definitely if you have endometriosis, previous surgeries, you're overweight, that's where the risk goes up a little bit. So that's, again, things, I'd be very personalized to you once we had a consult and kind of went through everything. But again, for the most part, very low risk procedure. You wake right back up, you recover for about 45 minutes. Definitely you're going to have some cramping and bleeding for about a day. And then the bloating usually goes on for a few days. The day of, absolutely you want to take off from work, but typically by the next day, most people are feeling pretty well. Some patients have lots of eggs. So for example, if you had polycystic ovary syndrome and we get like 30 eggs or something like that, definitely you're going to have more symptoms and maybe need to take another day or two off from work. But definitely the egg retrieval, that's our big procedure. We're going to get the eggs out. And then at that point, our lab takes over. So on the day of the egg retrieval, we would be getting either a fresh sperm sample from your partner, or we'd thaw donor sperm, or if you had a frozen sample. And at that point, for most people, I would recommend ICSI, which is intracytoplasmic sperm injection, which is the picture on the right. That is basically picking the best, fastest moving sperm under the microscope and literally injecting it into the egg to maximize the chance that it's actually fertilizing. Kind of older, what we call insemination for the IVF cycle is just putting sperm on top of each egg, but it's not making sure they come together. And that's what a lot of people need the IVF for. Older eggs need that to really get the sperm past that harder shell. Problems with sperm, we need to get that sperm in there. So that's where ICSI really helps. And so then the next morning, our embryologist will look to see which one's fertilized. So these are pictures. And so that day one is what we're hoping to see. So a fertilized embryo means an egg and sperm came together correctly, and we see two pronuclei and two polar bodies. Unfortunately, even if we inject a sperm into an egg, it doesn't always become an embryo. So that day after, you get your update as to how many normal fertilized embryos you have. Also to note, not every egg we get out, unfortunately, is a good, usable, mature egg to even ICSI. So IVF is all about numbers and unfortunately about dropout. So let's say we get 15 eggs, hopefully maybe 13 are good, mature ones. ICSI rate for most people, at least here at HRC, is about 80 to 85%. That could be lower for older age or poor sperm. But let's say we're down to 11 embryos. We then grow the embryos in our laboratory for a week. And so you can see these pictures. Basically, they're multiplying and dividing. And around day 4, they start to become what's called a morula, where they're starting to really organize itself. You can see that day 5 picture is what's called a blastocyst, which is what we're trying to get. It has a ball of cells that are in the corner kind of organizing itself. That's going to become the baby's body, hopefully. And then the outside part is what's called the trophectoderm, and that's what's going to become the placenta. We can get a blastocyst on day 5, day 6, and at HRC, we're even look again day 7. And so whenever it becomes blastocyst, at that point, definitely we recommend testing, or if you weren't doing testing, we'd freeze it or we could transfer it. But like we said, really, we don't recommend fresh transfer nowadays. And that's really because we recommend pre-implantation genetic testing, which is PGT. So when an embryo hits the blastocyst stage, the embryologist will take a few cells from that outside placental area, which is called the trophectoderm, do for everybody just full chromosome testing. So all of the chromosomes, Down syndrome, things like that. If you want to know gender, we can tell you, or we could keep that blinded. And then if we're also doing a specific gene test, we would do that as well. The thing to understand is, like we said, there's a lot of dropout. So from a fertilized embryo to a blastocyst embryo, really depends on age, but we could see a dropout anywhere from 30 to 60% higher dropout as we get older. So we know that that number goes down dramatically. And then when we do this testing and we get our report back, we see a huge dropout. So this is an example of a report. This patient, she's 36. She got 10 blastocysts, which is really good. And we get this report back and we see we have 4 normals, meaning that all cells tested were normal. She wanted to know gender, so we can see gender here. We have 1 boy and we have 3 girls. And so that's great. So each one of those should hopefully have a good 70-ish% chance of hopefully getting her pregnant. Also on the report, though, we see, unfortunately, there's some abnormals. So we see that the embryo number 4 has an extra chromosome 22, which is called trisomy. The one below that's the trisomy 16. Those are all things we know are not compatible with life, but by getting this information, we know we aren't going to transfer that one. And that's how we have such high transfer rates. In between a normal and an abnormal is something called a mosaic. So mosaics mean that the cells were tested and some were normal and some were abnormal. So you definitely want to be at a lab that reports mosaics, which is HRC. We report it very specifically. A low-level mosaic means most cells were normal, but a small percent were abnormal. It would be an embryo we might consider using in the future if we had nothing else. A high-level mosaic means most cells abnormal. At least right now, we would not consider that usable, but definitely you want to be at a lab that reports that whole spectrum. Labs that don't report mosaics, that's when you hear the cases that an abnormal embryo maybe was normal because it was probably mosaic. If you're at a lab like HRC, we use our own lab called NextGen, we know we're getting this report. So if it is coming back abnormal, like kind of embryos 4 and 5 and 7 and 9, we know that all cells tested were abnormal. It's about 99% accurate that those cells tested represent the baby. So definitely you want to be at a lab that gives full testing so that you can really know what's going on. So now we have our report. We know which embryos are good. Now we want to get you ready for transfer. So definitely we want to check inside your uterus. That could either be a saline ultrasound, which is that black and white picture where we put water in. The bottom one, you can see that big thing coming out is actually a little, not a little, it's quite large, a fibroid or submucosal, or sometimes it could be a polyp or whatever it might be. And then the picture next to it, that is what's called a hysteroscopy. That's when it's kind of like a colonoscopy of your uterus. We go in with a camera and we're able to see and take abnormal things out. But basically we want to make sure your uterus is normal before transfer. And because we know IVF hormones can change things, cause things like polyps to grow, definitely we want to do that close to when you do a transfer. So if you did it a while before when you first came in to do a workup, I always like to repeat it and make sure nothing's changed. Back to that slide before the IVF stimulation, we again want to optimize health. So we're check your thyroid again, make sure you're on vitamins. For transfer, really, it's prenatals with DHA. That's important. You don't need the coenzyme Q10. Again, healthy lifestyle. Definitely if we're trying to do something big, like, lose a lot of weight, Usually we say, let's try to get the embryos. That's very time dependent in terms of your eggs on your age. Whereas once those embryos are frozen, and like we said, with the chromosome testing, we know they're normal and they have very high chances. They're just as good to use this month or in a year or in multiple years. So definitely before we go use that precious, really nice embryo, we want to make sure everything's optimized as much as possible. At that point, we are ready to do our transfer. And so there's definitely some special considerations. If we only have one normal chromosome embryo and we don't think we can get another, whether that's because of age or financials or whatever it might be, prior to your actual transfer, we might do even more extensive workup. So there's something called a mock cycle with an endometrial receptivity assay, or ERA. That is to confirm what's called your window of receptivity. The thought is that there's about a 12-hour period of time that your uterus is most receptive. So we definitely want to be doing your transfer during that time. For most women, it's pretty similar. So our protocol, at least my protocol here at HRC, about 80 to 85% of women are going to fall in their window of receptivity. So that being said, if you have a couple embryos, just from a cost-benefit analysis, usually we go forward with transfer. But if we only have one and we don't think we can get another, that's where sometimes we have you do the full transfer cycle. Hormones, injections, everything, ultrasounds, blood work. And on the day you would have had a transfer, we actually do a biopsy for this endometrial receptivity assay. Like we said, typically maybe only 15 to 20% of women are actually going to say they need 12 or 24 hours less or more. But definitely that could change your pregnancy rate. So definitely we'd want to know that, especially if it's your only embryo. A lot of cost-benefit analyses have really shown it's not worth doing if we have multiple embryos until we've had failed cycles. But again, if you were very strongly wanting to do that, we could definitely consider it. Other times, again, kind of depending on your case, your history, if you've had miscarriages, how many embryos, we might do other types of endometrial biopsies to look for types of inflammation. There's something that actually can look for endometriosis off of biopsy. Because if that was the case, or you have a strong history or a known endometriosis, sometimes we'll also give you suppression medications for even 3 months before the transfer. So again, those are special considerations. And again, that would be very personalized to you based on your history. But now we're going to get into the actual transfer. So we're ready for transfer. Really different ways to run a transfer protocol. Medicated cycles, that's where we're going to definitely want to build your lining and then make it receptive with progesterone. So different medications to do that. Sometimes some birth control or Lupron to start, and then different forms of estrogen and then progesterone. Natural cycles, typically we'd say they're modified natural, is really following your own follicle to build your own lining. And then we trigger it just so we know how to time your transfer correctly. Stimulated cycles, if it's hard for you to get a lining, sometimes we're stimulate with pills or injections to get a lining and then trigger. So again, that would be very specific to your kind of individual needs. I always get the question, does it have to be PIO, which is progesterone and oil, or kind of the dreaded butt shot? Definitely if it's a medicated cycle, we absolutely see the studies show that it's superior to vaginal progesterone. If it's natural, definitely probably just vaginal is fine. Again, that would be something we would talk about. But PIO, that's kind of the big shot people obviously are nervous about. So definitely, we teach you how to do each of the shots. Some tips are here in the corner, icing the area before, but then warming the shot up and then kind of quickly stabbing it in, but very kind of letting it go slow just because it's such a thick shot, and then massaging and heat after. And definitely it's something, as your doctor, I'll work with you. Hopefully once we can get you to get to a heartbeat, that's where sometimes we say, all right, maybe we can back down on doing that every night and maybe do more vaginal. So, things that we can figure out as we go. And then in terms of how long do you actually take these medications, I usually bring my patients up to 10 weeks of pregnancy. The thought is the placenta takes over around 9 weeks. So in the 10th week, I'll check your progesterone levels. And if they've really bumped, it means your placenta is taken over and we can stop progesterone and stop estrase. Add-ons to FETs. Nowadays in the worlds of kind of social media and fertility forums and things, people kind of read and hear all sorts of different things. Again, lots of potential add-ons. This is, again, very specific to your case, your medical history, if you've had failed transfers or miscarriages. Steroids are thought to kind of quiet the immune system down. Usually for a lot of my patients, actually, I just do a Medrol dose pack, but definitely maybe a longer course of prednisone if needed. Baby aspirin, really good studies out there, especially with COVID and things. So I give everyone baby aspirin. Lovenox really would be only for specific patients with an indication. Intralipid infusions, the thought is they can quiet down what are called natural killer cells that make it harder for embryos to implant. Again, usually something I wouldn't probably offer the first transfer just because it's not that evidence-based. But again, if we only have one embryo, we might do it, or definitely depending on your history, we might do it. And definitely if we've had a failed transfer, we'd recommend it. Antihistamines, again, something out there depending on certain medical history, something like Mucinex. Definitely if someone has major mucus problems, so if they themselves have cystic fibrosis, or if we need some help kind of clearing out fluid, we would do that. And then lots of different thin lining regimens. So if we can't get your lining kind of past 7 millimeters, we're keep canceling, trying different types of cycles, and these are different things we can sometimes add to hopefully thicken it. But definitely lots of different ways to run an FET, so it'd be very personalized to your case. So you now finally have done your protocol, done everything. You have a beautiful lining. You're on your progesterone. Now it's time to actually do your transfer. Really, our strong recommendation, as well as the American Society of Reproductive Medicine, is a single embryo transfer, so one at a time. Back in the day that we didn't do chromosome testing, that's where we would put back multiple embryos. For example, at 40, the thought is maybe only 1 out of every 3 to 4 blastocysts is normal. So with doing chromosome testing, that's where, again, we're having lots of dropout, but we know which one's normal. And so that one normal is going to have a high chance. If we hadn't done the chromosome testing, yes, maybe we'd put back 2 or even 3. Again, just thinking 1 will be normal, but sometimes more than 1 are. But really with PGT, absolutely recommend single embryo transfer. If you very strongly desire twins, definitely we can chat about that. And based on kind of medical history and things, it could be a possibility. Another question is always, well, how do we pick the embryo? So if you'd like to know, we can tell you gender. And if you have both, you can pick if you have a preference. Otherwise, we can pick the best one, and the embryologist will do that based on the grading. Grading is also something that's very kind of different from place to place. Here at HRC, we're very strict graders. We're really grading the inner cell mass and the outer cell mass. Even that, though, is a little subjective. So they're pick the best one based on the grade and, if it was an earlier blastocyst or later. But really, the difference between a perfect AA embryo and maybe one that's a little bit less like a BC, it definitely could be a couple percentage points. But if you have a strong gender preference, we'd still probably go with the gender. But that would be something we'd chat about before picking which one we're going to thaw on the day of your transfer. On your day of transfer, obviously the day you're kind of looking forward to this whole time, you're come in. A lot of times some people will have different things like acupuncture or things like that just to help with stress reduction. The transfer itself is literally a couple minutes. If you have a partner, they can come with you. Or if you need anesthesia, that would be something that would be in the operating room, so it would not be with a partner. But basically you get to see everything on the screen. We're put the catheter in. You literally see it go up. You're seeing that little picture on the bottom left, and you see a little bright white flash, which is typically the embryo's air bubbles around it. We confirm that the embryo didn't get stuck in the catheter. And at that point, you're pregnant until proven otherwise. You literally go home, about 15 minutes later. And really at that point, definitely we want you to take it easy. So lots of studies out there, really, they've shown you don't need to be on strict bed rest, but again, you want to take it easy. So no major exercise, don't raise your body temperature, don't go sit in a sauna or something like that. Anything you can do to try to decrease stress. Also really hard, but the progesterone unfortunately causes a lot of the same symptoms as pregnancy. So, do your best to just kind of survive that 2-week wait. Different places check different days for that first beta. So it's kind of dependent. We like to do the 12-day. Unfortunately, there are embryos that might slightly cause a positive beta if you're checking it really early and then they don't stick. So we prefer to kind of know that the ones that come back with a good beta definitely are good, hopefully sticky pregnancies. If you do want to test on your own, definitely you want to wait a good week or so. Use a good test like a first response or early result just because it's super early. And then remember your hydration really impacts it. So if you're checking it every day and it's not definitively getting darker, that's not necessarily a bad thing. It definitely could just be your urine is more dilute or concentrated. concentrated. Never stop meds without getting a blood draw. The blood draw is the most accurate, and that's what we're going to hopefully be following. Hopefully when we get that big fat positive, hopefully we follow your blood work a few times. And then at least in my practice, I like to do ultrasounds at 6, 8, and 10 weeks. Make sure everything looks good. And at 10 weeks, we'll graduate you to your OBGYN, which is obviously always bittersweet. We're excited, but obviously sad to see you go. Just because I know there's a lot of interest. That was kind of IVF in a nutshell. I know it's a lot to cover in kind of a short period of time. And like we said, a lot of that would be more personalized if you did a consult. But IVF also includes a lot of other things. So embryo freezing is IVF. It's basically making embryos with the intent to transfer in the future. Like we said, those embryos have the same chance of that good high chance to transfer to lead to pregnancy now, in a year, and 10 years. So embryo freezing is great. Donor egg with either fresh or frozen eggs also uses IVF. So you can either have a donor go through the Ivf cycle to get the eggs, or we can get frozen eggs from an egg bank, thaw them, and then we still do the rest of that Ivf process we talked about. So we do the ICSI to combine with sperm, we grow the embryos, we do the chromosome testing, and then we would do the transfer. Sometimes people will use a surrogate for that transfer for medical reasons, elective reasons. So the surrogate would then be carrying your embryo. Reciprocal Ivf is very popular. So especially for lesbian couples, one wants to, we will use her eggs, and then the other one can carry, and it's a great way they can both be part of the process. Egg freezing is also really the first part of IVF. So everything we talked about for stimulation to the egg retrieval is egg freezing. But on the day of your egg retrieval, the ones that we would have combined with sperm are basically frozen. And then in the future, we thaw them and then go through the rest of the IVF cycle. So that's a great way to essentially freeze your fertility. Definitely with any of this, IVF, egg freezing, embryo freezing, the earlier you do this, the more eggs you get, the better quality, the more likely they'll be normal. So egg freezing is just getting more and more popular. So that's a great way to kind of start the IVF process to have a better result. And then I just threw an Invicel. It's not exactly IVF. It's almost kind of in between an IUI and IVF. Invicel is the injection, kind of like IVF. It's the egg retrieval to take eggs out like IVF. But at that point, we don't use the laboratory. We literally combine eggs and sperm in a little kind of container that you would literally wear in your vagina kind of to incubate it for 5 days. Come back, we look for your embryos, pick the best one, do that fresh transfer, and then the others are frozen. Here at HRC, because we're not doing the intracytoplasmic sperm injection, we aren't going to do pre-implantation genetic testing. The success rate is definitely much lower than regular IVF, but it's higher than an IUI. Really, that would be for very specific people. So that would be a way that lesbian couples could do kind of reciprocal IVF in a little bit of a cheaper, kind of easier way. Definitely someone who wants to make extra embryos that maybe doesn't have a definitive tube problem. They're young, they have good eggs, they have good sperm. That would be a good option. Really not for someone though older, poor sperm, unexplained infertility, because we're not doing the big parts of IVF that make it so successful. We're not putting sperm into the eggs, which is ICSI. We're not doing chromosome testing, but it is definitely something to be aware of. So that's kind of all of IVF. We're going to start doing some questions, but real quick about HRC, like we started off with, we're here in Southern California. We have 9 locations, kind of the 3 big IVF laboratories. So Newport Beach, where I am, Pasadena, and Encino. We have 12 fellowship and board certified REIs. We have fantastic pregnancy rates. And so we're very proud of our practice. Specifically, like I said, I'm here in the Newport Beach in the Orange County office. We have very high pregnancy rates, top of the national statistics. And so we are just very proud to have such great stats. And then a little bit more about me. I've been practicing a little over 5 years. Prior to HRC, I was an attending physician at Columbia University Fertility Center in New York City. I did, full fertility care, as well as I ran the egg freezing and oncofertility program. Prior to that, I did all my training at Columbia and residency fellowship. I was at Georgetown Medical School before that. I love doing kind of media appearances. I've been on the Today Show a few times. So I definitely, I love kind of educating and working with patients and just kind of getting the information out there about fertility. So at this point, I'd love to go through some questions. I'm just kind of pulling up kind of some questions that you can see here on the question form, as well as some of the questions that were sent in before, just to kind of do these ones live, since I know these patients are on here. Kind of how many eggs should an average 37-year-old freeze for one baby? That's definitely a great question. If we're talking about egg freezing, the issue with egg freezing is we don't get all of the information about your quality up front. So we'd always rather get many more eggs than we might potentially need, just because we don't want to find out that you have lower than average quality, when you come back at 42 or whenever it might be, and you have much less chances. So at 37 for one baby, ideally you'd get a good kind of 15 plus eggs, with the thought being is that not all survive the thaw, and definitely not all will become an embryo, and not all will be normal. But that would be something also depending on medical history, what your actual hormones look like in terms of what we think the quality is. For TSH, definitely we like your thyroid being well controlled. Absolutely. Different kind of thoughts out there. I know you wrote controversial, definitely kind of different thoughts, but the studies really show that for being pregnant, if your TSH is between 2.5 and 4, which is technically normal, anything less than 4 for a TSH is normal, but between 2.5 and 4, we see a high risk of miscarriage. So absolutely, before a transfer or before trying to get pregnant, we want your TSH less than 2.5. If it's 2.8 before just the stimulation of IVF, that's okay. Definitely we follow it. But before a transfer, we want to make sure it's less than 2.5. And there's good studies to show that. So that would be something if your TSH is 3.8, you don't have underactive thyroid, you do not have hypothyroidism, but we do know you would do better to be pregnant with it being less. And so as your fertility doctor, I could give you a little dose of thyroid medication. If we do this whole workup and we find your TSH is very high, so it's 6, that means you have hypothyroidism or underactive thyroid. I'm going to refer you to a medical endocrinologist for a full workup, just so that they can fully check your thyroid, do ultrasounds, do all of the blood work, and be able to monitor that throughout pregnancy. But definitely thyroid is important. Chinese herbs, that's definitely a great question. Chinese herbs are a little hard because some of them are just kind of mixed, and we're not really certain what's in them. Ones that have phytoestrogens, which a lot of them could, definitely not something we want to mix with the IVF process where we're trying to check your blood estrogen levels a lot. So if you're trying to get pregnant not using IVF, they definitely could be helpful. If we're doing IVF and testing, the ones that we talked about that are definitely evidence-based, coenzyme Q10, some of the others, depending on your history, those would be great, but I would stay away from Chinese herbs during the IVF process. Acupuncture, which a lot of times they kind of go hand in hand, the needle part of it could definitely be helpful. It can decrease stress. It can increase blood flow. But we always put that caveat, please don't use the actual teas or herbs or anything. In terms of will that actually increase the follicle count, that's probably not typically. Usually we're thinking it's a little bit more on the quality side. There's a question, can a patient decide if they do ICSI or not? Definitely you can. Absolutely, the recommendation for almost everyone would be ICSI. So as we get older, the egg is harder for a sperm to get into. So that's why you want to do ICSI. If there's anything on the sperm side, like a even slight morphology defect, definitely ICSI has higher rates. If you have unexplained infertility, you absolutely want to do ICSI. So really the one kind of group that sometimes maybe would consider not doing ICSI would be if you're using really young sperm, like a donor sperm. But even with that, we still see higher rates with ICSI for more embryos. And it also sometimes just helps in terms of making sure we're getting good reads on our chromosome testing. If we're doing just chromosome reads, really we don't have to do ICSI. Definitely if we're doing checking for specific genetic mutations, we have to do ICSI to make sure there's not extra genetic material floating around. Is varying egg size a common problem? I think that question is kind of about the follicle. So definitely follicles, those are the black circles we can see where the eggs are. Definitely they vary. And so that's why for a lot of my patients, I really like to start you on something to synchronize them before we go into the injections. So birth control or luteal estrase, and then follow you closely, just because yes, they're not all going to grow exactly at the same speed, but we do our best to try to get them to grow similarly, just so that we can get as many to grow as possible. If you have one or two that go way too fast, that's when we get less eggs. So yes, it definitely happens. It's more common as we get older, but that's where having a good protocol and having a doctor that monitors you closely, usually we can try to keep that from being too much of an issue. How long is the process from start to finish? So that's a great question. The first part to make embryos, because usually I do, let's say 2 weeks of birth control or whatever it might be. That's usually about kind of 2 weeks of the pill, 2 weeks of the injections and taking the eggs out, and then a week to make embryos, and then another week to get the results. Usually, especially if you have a good response, I would have you take a month off in between doing the egg retrieval and the transfer cycle, again, to maximize health, get all those hormones out of your system, check your uterus, and then the next month do a transfer cycle. And that, again, depends on what type of transfer cycle we're doing. But usually from the day you get your period to start to actually getting a transfer, kind of the quickest maybe is about 2.5 months. Usually it's hitting more towards like 3.5 months. But that would be something kind of based on your history. We could kind of have a little bit more of a plan. Can you test eggs for health or just fertilized embryos? That's a good question. Unfortunately, you can't check the eggs. They're just one cell. So if we tried to do testing on it, we would kill it. And same thing with the sperm. So that's why we have to get embryos. And that's why freezing eggs is awesome. It's just you need to have that idea that there will be dropout. So we want to freeze extras so that if there's more dropout than expected, when we get to that testing, we have extras. I see someone saying the oil is painful and I'm allergic. There are some alternatives. There's different types of oil. So if you have a peanut allergy, we flag that in the chart. We would put a different type of oil for your progesterone. There's lots of different ones. So I've never had someone who's allergic to every single one. So we figure out which one is the best. Like we said, if you absolutely can't do injections, there are different types of progesterone vaginally, including gels. So we can figure that out. How long do you recommend waiting in between IVF cycles? That's a great question. There's a lot of good data now. We're actually going right into your next cycle. We could actually maybe do better your second cycle. The thought is all of the hormones, the first cycle, almost kind of prime the ovary a little bit so that when you go right into the next cycle with your next period, you maybe get a little better of a response. I would say about 15 to 20% of women, though, they come in trying to do those back-to-back cycles and they still have really big follicles recovering. So those patients I'd have wait another month. But for other people, if everything looks good, we usually go right into your next cycle and you do really well. And then if you're interested in having twins, how many embryos should we transfer? So definitely, like we said, we want to just make sure medically everything sounds good. We want to be of a good body weight, no history of major surgery in the uterus and things like that. But for twins, because we have such a high chance with just the one, we would put back 2 with a good chance of twins. What FSH level is too high for IVF? That definitely is a good thing to point out. So FSH increases as we get older. Normal is less than 10. For hopefully a reasonable response to IVF, we really like it less than 15. Definitely once we're getting over 20, there's an unfortunate chance you might not respond at all. In my practice, my cutoff would be 25. But again, over 20, I would strongly counsel you that we could try, but unfortunately, kind of in that 25 range, some people respond, some don't. But I'm more than willing to try with you. I just want to be upfront, make sure kind of ethically everyone knows kind of what the chances are. I had a patient actually last month, her FSH literally was right there kind of at 25. She did respond. She got 2 eggs. Unfortunately, we didn't get a blastocyst, but she went right into her next cycle. And this month, we're about to do her egg retrieval. She's coming back tomorrow for monitoring, but I think her egg retrieval will probably be on Friday. It looks like now she has 6 follicles growing, so definitely a better response, and that's kind of where that back-to-back cycle can especially help someone with poor ovarian reserve. Let's see, there we have a male and a male partner. We have an egg donor, a surrogate. So in terms of price, definitely I would have you talk to our financial advisor. We have some packages. So definitely that would be something where we could have you talk to the financial advisor just to get a little bit more information. But if you already have an egg donor or a surrogate, that, finding that can definitely be, time and cost. So if you already have that in legal and psychosocial, definitely it could be more reasonable, but absolutely that would be something a financial advisor could go through. So yes, definitely you want the best fertility out there. You want to make sure you feel comfortable. You want to make sure your doctor's really involved. Different styles out there. So you just want to make sure you feel kind of involved with your doctor. Like I said, I like to concentrate definitely obviously on the medicine, but also on some of the other aspects. Some other doctors are a little bit probably more kind of concise, I guess, if you want to say, in terms of just talking quick medical. You also want to see what is kind of your day-to-day part of IVF. So if you're donor or you yourself are going through the cycle, I like to do a lot of my own scans. So you're seeing me. If I'm in surgery or the time doesn't work for when I'm open, you see an ultrasonographer, but I still see all the pictures and I'm still fully involved. HRC is a bigger practice, but each of us doctors have our own team within it. So it's still a very small kind of personalized experience per doctor. So it's me. I have 2 main coordinators and then some other coordinators that also help. So you're always seeing kind of the same people and hopefully feel like it's very very personalized. Do we need to get a referral to see you? That depends on your insurance. Definitely you can call and make a consult, and as part of that consult pre-workup, our financial advisor will do a benefits check for you. If you have an HMO, unfortunately some HMOs require you, yes, to get a referral from your regular doctor to, whatever specialist you're seeing. So definitely we could look into that and help you figure that out. Definitely the referrals and things like that can take some time. We have great specials on consults, so definitely we could figure that out, at the time. And then is there such a thing as an AMH level being too high? That's a definitely interesting question. So AMH is what comes from the eggs. That's a number that goes down as we get older. For someone with polycystic ovary syndrome, though, they usually have a high number of follicles and high AMH. So kind of normal AMH, anything over 2 is really good. It's specific to age. Over 4.4 is highly linked to AMH, to PCOS. And if your AMH is off the charts, like 20, yes, that's kind of very high. The concern is you have severe PCOS. And even though you have a lot of AMH and follicles, it's very hard because you're so severe and kind of resistant to get the medications to work. But that's where, again, we would do maybe some metformin. We would do a lot of things before to really get the ovaries ready. And then you'd get a lot of eggs. So we'd have to monitor you closely, make sure you don't get like 50 plus eggs, because then you have a lot of symptoms. But that's definitely something we work with. So we can figure that out once we see all of your stuff. Great. I love it. People say they've gotten a lot of good information, which is great. Let's see, if you've had prior surgery, removal of an ovarian tube, definitely, it again would kind of, why did you have that done? Do you have scarring? Definitely carrying twins is a much higher risk pregnancy. You have a much bigger uterus, definitely higher risk of things like preeclampsia and things like that. So again, it's not a definitive contraindication, but I want to look into it a little bit more. Human growth hormone, that is an awesome question. So human growth hormone or Omnitrope, definitely something that's not definitively evidence-based. I do like Omnitrope, especially I see you said you're 43, definitely for someone who's a little older, if they have very low ovarian reserve, if they've had a failed cycle, absolutely would add Omnitrope. The studies right now show it increases the number of eggs. Unfortunately, it has not been able to show that actually increases our usable kind of embryos or our pregnancy rates. But definitely more and more studies, kind of more and more literature. So it's kind of leaning towards becoming more standard of care probably over the next few years. So yes, Omnitrope, if we're a little older, or very poor ovarian reserve or a failed cycle. Insurance, it depends if it covers different things. So that's definitely where a financial advisor could look into it. Some states are very mandated, like Massachusetts. Unfortunately, even though we're pretty progressive here in California, it's not a full mandate, but definitely that'd be something a financial advisor could check. But some insurances do fully cover all of this, which I know is not fair for people that don't have that coverage. Recommendation for exercise and type of exercise up and during to IVF. So definitely exercise is great. You want to be active. That helps with kind of everything that you're going through. It helps reduce stress, keeps you a good body weight. Definitely you don't want to massively increase your exercise regimen right before a cycle or right before a transfer. That kind of confuses your body. But if your body's used to it, you can keep doing that through it. In the actual injection part, when your ovaries are starting to stimulate, for the week before and the week after, we'd have you hold on any major exercise just because we don't want you twisting an ovary. But we would give you more specific instructions. And then just in general, sometimes people say, well, what's too much exercise? Definitely if you do aggressive high intensity interval training, like multiple times a day or something like that, that would be too much for either male or female. So just, moderate exercise is great. We would give you specific instructions as to when not to do that during the actual injections. How often do we find that IVF patients need thyroid hormones? It really, in general, I'd say maybe about 10 to 15% maybe need a little bit. Maybe 5% of that are people that really are going to need to go see an actual endocrinologist, but the rest are just, again, that borderline range. High cholesterol, definitely, again, anything we can do to optimize your kind of health. And so HDL is typically considered a good one. If it's super high and we think there's things along with triglycerides and everything, again, we'd have you kind of go through your primary care doctor, but definitely any type of medical problem, including cholesterol issues, we want to try to get under control first. Would you recommend someone start to consider IVF after trying naturally without success? So that's a great question. That's definitely where we do at least some fertility testing, and based on age. So over 40, typically we'd recommend going straight to IVF if you're having issues, especially after 6 months. Kind of over 35, again, definitely we could consider IUIs or IVF. Less than 35, again, we could absolutely go straight to IVF, but with that, sometimes we try IUIs. So it's really kind of depending on your exact fertility testing, but also your preference and other parts of your medical history. So these were all some fantastic questions. Just to touch on some ones that were sent in before. Like we said, a lot of them were very specific kind of to people's situations, but there were definitely some good questions asking about how to do IVF with donor eggs. So just to go into that a little bit more, fresh egg donors are something we would help you find, usually through an agency, where that person would go through IVF, and on the day we take the eggs out, if you have a partner, we'd use his sperm to fertilize, or we'd use a donor sperm, grow embryos, and then you or a surrogate would carry the pregnancy. Frozen eggs are also super popular now. Here at HRC, we work a lot with the Fairfax Egg Bank. We have great success with them. Literally, you go on it. Literally, it's a website. You can pick a donor and ship eggs to us, and we would thaw them, and then same kind of thing. So then basically, once we have those eggs, we're doing this full IVF process we just chatted about. Let's see, just looking at anything else. So yeah, so I hope you guys got a little information. I know that was kind of a whole hour of everything, but at this point, definitely, I hope you got what you came here for. Absolutely would love to do a consult with you if you're interested in care, or one of the other HRC doctors. Again, we pride ourselves on really high success rates, personalized care. So whatever your journey is or wherever you are on it, I wish you definitely a lot of baby dust and good luck, and reach out if there's anything more that we could answer or do for you.